If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we're looking at the new updated NICE guideline on type 2 diabetes in adults, always focusing on what is relevant in primary care only. The diabetes guideline is a comprehensive document, so I'm breaking it down into clear and practical sections. Today we're focusing on medicines management, including sick day rules and choosing initial medicines. In recent episodes, we covered the initial sections of the guideline, and in future episodes, we will move on to further drug treatment and the management of complications. Right, let's jump into it. When discussing medicines, we should go through the benefits and risks of each option. This includes the effect on HbA1c and weight, the effect on cardiovascular and renal outcomes, whether there are contraindications such as pioglitazone in heart failure or metformin when eGFR is below 30, practical issues that might affect adherence, and cost. If two medicines from the same class are equally suitable, we should use the least expensive option. If a person has more than one comorbidity, for example, atherosclerotic cardiovascular disease and obesity, we should make a shared decision about which condition to prioritize. When discussing GLP-1 receptor agonist or tirzepatide, we should explain the guidance on use in pregnancy and breastfeeding. We should explain that weight loss may improve fertility and that effective contraception must be used while taking these medicines. And if pregnancy is planned, contraception should continue for a period after stopping treatment. Now let's move on to sick day rules. We should include clear sick day guidance in each person's individual treatment plan. Depending on the medicines they're taking, this should cover whether medicines need to be adjusted during illness or surgery, whether medicines such as metformin or SGLT2 inhibitors should be temporarily stopped if there is a risk of dehydration, vomiting or diarrhea, how to adjust insulin doses, and how to restart treatment after recovering. Before initiating treatment, we should assess cardiovascular and renal status and the person's future cardiovascular risk. If frailty is a concern, we should assess this before starting medicines. Frailty can change the balance between benefits and harms. Let's now move on to initial medicines. This section sets out what we should start at diagnosis before insulin is needed. The recommendations are grouped by clinical profile. Let's go through them one by one. First, people with no relevant comorbidities. For them, we should offer dual therapy with modified release metformin and an SGLT2 inhibitor from the outset. If metformin is contraindicated or not tolerated, we should offer an SGLT2 inhibitor alone. So the default starting point is dual therapy. Next, people with heart failure. For adults with type 2 diabetes and heart failure, regardless of ejection fraction, we should again offer modified release metformin and an SGLT2 inhibitor. If metformin cannot be used, we should offer an SGLT2 inhibitor alone. Now let's look at people with atherosclerotic cardiovascular disease. Here we should offer modified release metformin, an SGLT2 inhibitor, and subcutaneous semaglutide up to 1 mg once a week for its cardiovascular, renal and glycemic benefits. If metformin is contraindicated or not tolerated, we should offer an SGLT2 inhibitor plus subcutaneous semaglutide. So in this group, initial therapy is triple therapy, reflecting the very high cardiovascular risk. Next is people with early onset type 2 diabetes. Early onset means diagnosis under the age of 40. For these adults, we should offer modified release metformin and an SGLT2 inhibitor, and we should consider adding either a GLP-1 receptor agonist for its cardiovascular, renal and glycemic benefits, or tirzepatide for its glycemic benefits. If metformin is not suitable, we should offer an SGLT2 inhibitor and consider adding a GLP-1 receptor agonist or tirzepatide. This reflects the higher lifetime risk in early onset disease and the need for more intensive early management. Now let's look at people living with obesity. For adults with type 2 diabetes who are living with obesity, we should offer modified release metformin and an SGLT2 inhibitor. If metformin is contraindicated or not tolerated, we should offer an SGLT2 inhibitor alone. Obesity itself does not automatically change the initial dual therapy recommendation, but it will influence later choices. Next is people with chronic kidney disease. We need to tailor treatment according to eGFR. If eGFR is above 30, we should offer modified release metformin and an SGLT2 inhibitor. If metformin is not suitable, we should offer an SGLT2 inhibitor alone. If eGFR is between 20 and 30, we should offer either dapagliflozin or empagliflozin together with a DPP4 inhibitor. If eGFR is below 20, we should consider a DPP4 inhibitor. If a DPP4 inhibitor is contraindicated, not tolerated or not effective, we should consider pioglitazone or an insulin-based treatment. So, in advanced kidney disease, the pathway shifts away from metformin and SGLT2 inhibitors, depending on renal function. Finally, it's people with frailty. For adults with type 2 diabetes and frailty, we should offer modified release metformin. We should only offer an SGLT2 inhibitor if a person's level of frailty does not place them at risk of adverse effects, such as volume depletion or hypotension. If metformin is contraindicated or not tolerated, we should assess frailty carefully. If frailty does not increase the risk of adverse effects, we should consider an SGLT2 inhibitor alone. If frailty does increase the risk, we should consider a DPP4 inhibitor instead. So that is it, a review of the section of the NICE guideline on type 2 diabetes. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.